Okay, I think we'll get started though. It is behind time. As I just mentioned, we're terribly sorry for this technical issue, which seems to do with having created a different Zoom account and not having permissions, but we will get that sorted for sure next time. My name is Susan Law, and I'm the Knowledge Mobilization Lead for Long COVID Web, and I'm here with Angela Chung, who's the principal investigator for this initiative. And thank you all for attending and for being persistent about navigating your way online here. I'm going to start with a land acknowledgement. We wish to acknowledge this land on which the Long COVID Web operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Thank you. Just turn to Angela if you have any opening welcoming comments.
No, so just want to welcome everyone as well. And we try to have this series of webinars that are pertinent to both scientists, clinicians, and patients as well. And so your feedback on future topics is welcomed.
Thanks so much, Angela. And just to reiterate what the objectives are here today, it's really as a mechanism for sharing evidence-based information that are relevant to the groups that Angela just mentioned: decision makers, researchers, clinicians, patients, caregivers, and the general public. Secondly, to provide ongoing updates, spotlights on emerging evidence, and scientific information about the activities and research results from our web members and the network of researchers. And thirdly, to contribute to reducing and managing misinformation about long COVID. And today I'm very delighted to welcome two topics and three speakers. First on prevention, and then second we'll hear about the current variants and vaccines with relation to COVID. So a few logistics: your cameras and mics are off, but the chat is open to your questions throughout the presentations. And Angela and I will do our best to get to all of them before the end of the session, but we will aim to end at 2, so it'll be somewhat abbreviated. Apologize for that, but we will be recording this and it will be posted shortly after on our website. Lastly, we just do welcome your thoughts about how these sessions could be more helpful to you, so thanks. So I'm going to begin now by turning to Drs. Filiatrault and Dr. Bhéreur to share their insights on prevention of infection and reinfection, and including lessons and tools from our experience with the pandemic to date. Thanks. Over to you.
Thank you. Start that. So I will start us off. My name is Dr. Alon Vaisman. I'm a retired emergency physician from Vancouver. And next slide, please. And I'm now part of an advocacy group, actually several advocacy groups that you can see listed below. Anne Bhéreur is a family physician and palliative care physician in Montreal who has been dealing with long COVID since December 2020. And she is using her precious energy to make a difference when it comes to long COVID. And she's an active member of the Long COVID Web, as well as a member of advocacy group as well. Next slide, please. So we're in this brief time, we're going to go through where we're at with the COVID-19 pandemic. Some of the lessons that are learned and still need to be learned. We'll shift then to how do we prevent COVID in order to avoid long COVID and post-COVID condition. And then we'll come full circle talking about going upstream to get to a better place with COVID. Next slide. Okay, moving along. Next slide. So is COVID over? Answer, no. This relates to the 4-day event by the U.S. Center for Disease Control. It was their first in-person conference in since 2019, and lo and behold, it was named
Epidemic intelligence surveillance.
And lo and behold, that was a misnomer. It ended up being a super spreader with about 10% of participants being infected. So 181 COVID infection in guests and staff. And of course, 10% of these individuals will likely go on to develop long COVID. So how not to lead during a pandemic. Next slide. This slide
Lynn,
is
excuse me, Lynn. There was a comment that at least one participant is having a bit of trouble hearing you. I don't know if you could turn up your input or speak a little louder. Thank you.
Okay, let me try without the, is that better?
Yes, thanks.
Okay, so this is from Our World in Data, and it shows the number of COVID-19 hospitalizations currently in Canada. So as you can see, during Omicron, since December 2021, there's been actually quite a burden of COVID in our hospital. And we've never gotten to the lows that we saw early in the pandemic. So if you look at what happened just before this fall surge, the lows in hospitalization are higher than we've seen early on in the pandemic. I advise you to take a screenshot of this slide so that next time somebody tells you that COVID is just a cold or that it's seasonal, you can show them this slide. So COVID is essentially a all year, every season infection. Next slide. Essentially in Canada, there's no public health when it comes to COVID currently. The best source of information when it comes to protecting yourself and knowing what is your level of risk in your province or territory is through the work of Terry Moriarty and the volunteers at COVID Resources Canada. And what you see right now is for the 2 weeks of November 4th to November 17th, the risk of acquiring COVID is severe in every single province and territory. In fact, currently in Canada, 1 in 25 people are infected. So it's not over. Next slide, please. Next slide. The first lesson is that SARS was a dress rehearsal for SARS-CoV-2. And SARS was aerosolized or spread by aerosol. This is a quote from the SARS Commission, and what it refers to is that what started off the global outbreak was a physician from mainland China, from Guangdong, who was at the end of February 2003, was staying at the Metropole Hotel on the 9th floor. He had been looking after patients with atypical pneumonia and became infected himself, but thought he was well enough to attend a wedding in Hong Kong. Unfortunately, he never made it. And in fact, he passed away, but not before he infected 17 people on the 9th floor. 16 of them were guests. One was a local from Hong Kong who visited someone staying on the 9th floor and happened to walk by the room of the physician, the Chinese physician. And you can see here the quote from Justice Archie Campbell, trying to explain how could it be droplet and contact spread when the physician had absolutely no contact with any of these individuals. Canada had the second biggest outbreak outside of Southeast Asia, and SARS entered via Toronto and Vancouver from returning guests from the Metropole Hotel. Vancouver applied the precautionary principle, isolated the index case within 2.5 hours of admission to our emergency department at VGH. And essentially, we only ended up with 5 cases and no deaths. Next slide. That SARS was spread by aerosol was known back in September 2020. The chief science advisor for Canada, Dr. Mona Niemer, put together a panel of experts from multiple disciplines. When you have a complex problem, you need disciplines from multiple sciences. And the engineers and environmental health sciences answered when asked, can it be spread by aerosol, or is it spread by aerosol? The answer came back a resounding of course. Dr. Fauci, that we all got to know, presented at the Beatty conference in McGill on October 1st and admitted his error, thinking it was droplet and contact spread, and basically shifted to aerosol, admitting that SARS-CoV-2 is mainly spread by aerosol, and now it's irrefutable with all the accumulated science. Next slide, please. This slide here shows Lindsay Marr, who is an engineer from Virginia Tech, showing during the 60-minute segment of October 29 what happens when people breathe. Simply breathe. This is the aerosol that we emit simply by breathing. So breathing is an aerosol generating procedure. Of course, you emit more aerosol if you're shouting, singing, or exercising. And over time, these aerosol accumulate inside a closed, poorly ventilated space, meaning that over time, you are likely to be breathing in infectious aerosol. Next slide. And this is what it looks like. So closer to the source, you're more likely to be infected by both small and large aerosols. You get a bigger dose. But if you're in the same space, indoors, this is an indoor pandemic, and you spend time indoors, over time, just like cigarette smoke, the person on the right-hand side is going to breathe in infected aerosol. So 2 meters does not matter. When you spend enough time indoors, you will eventually breathe in infected aerosol, particularly if there's poor ventilation. The big blue circles are droplets, and they play a role only when people are symptomatic. When they cough, they sneeze, they may have a role there, but it is a minor role. And in fact, there's very limited science supporting the role of droplets in SARS-CoV-2 spread. Next slide. And this is highlighted here because 70% of your transmission is from people that don't have symptoms. Either they'll never have any symptoms or they haven't developed symptoms, meaning they're not coughing and they're not sneezing, yet they're responsible for 70% of SARS-CoV-2 transmission and infection to others. Next slide.
Oh, next lesson. It's not only COVID. Post-infectious conditions have been pushed under the rug for decades. Long COVID is bringing into light what was in front of us for decades. There's no cures yet for any post-infectious chronic condition, only symptom management. We hope to turn the tables, but currently, best prevention of long COVID is avoiding COVID-19. Because long COVID is inclusive, and every infection is a gamble. Many of you know it all too well. And I'm pretty certain most people listening are aware of the whole iceberg of COVID-19. Too many of you currently live with many of these consequences and or research them daily. But human nature and public messaging, unfortunately, have a tendency to bury difficult things deep into the void. Being aware is not anxiety. It is empowerment to better protect, to do what's possible to avoid bad outcomes while enjoying life in good health. And talking about human nature, among the disciplines that have been sidelined, behavioral specialists and communicators could have helped establish more effective public education strategies and perhaps prevented the underwater portion of the iceberg from remaining so huge to this day. Multidisciplinary collaboration is essential in tackling difficult situations. Wicked complex problems require a wide range of collaboration. No one holds all the answers. We must stop repeating the same mistakes. And not to get carried away, I'll just stop at the political health that has trumped the laws of physics and scientific rigor. And we'll jump to the practical part of the presentation, practical ways curbing transmission. This is probably the only current clear message. Having symptoms, stay home. The days when going to work sick as a dog was seen as a strength are over. And even if it's essential to understand that not everyone has the luxury to be able to stay home, there are still ways to protect others when sick. But it's important to remember what Lynn said earlier. There's a lot of asymptomatic transmission from people who know or not they're infected. So relying on symptoms is not enough. There's a whole toolbox available to reduce the risks of transmission. Each have their flaws, but the more used together, the less chances there is that the whole will align. Not all layers will be addressed in those short minutes, We focus on breathing and on actually not breathing infected aerosols. Dr. Vaisman will talk about vaccines later, but it doesn't mean other layers are not still useful. And very important, everything counts. Will not work 100% of times, but collectively protecting means that overall there are less infections and consequences. First and foremost, we have to choose the right target. COVID is transmitted by aerosols, so aiming for upgrading protection against breathing in infected aerosols will have the most effect. Droplets and contact precautions are useful, but essentially for other things than COVID-19. Evacuation of anything bad in the air, whether infected aerosols or any kind of air pollution, is always a good idea and helps everyone. That is what ventilation does, with varying levels of fresh air intake. Filtration of recirculated air on mechanical systems vary a lot. Some might have adequate filtration, many do not. It's also often hard to know for public building, and unfortunately, bad public education has not yet provided for building owners to promote good air quality and take pride in it. At home, though, everyone should know that opening a window and running the range hood or bathroom fan can help circulate air when there's no mechanical ventilation. That's a good thing to remember when visitors come by. But remember that in this case, the bathroom might then be a good place to wear a mask, if not worn at all times. A good way to estimate indoor air quality and ventilation is CO2 monitoring. It's a good proxy to rebreathed fraction of air, meaning the air that has previously gone through lungs, yours or other people's, and lingers in the room. Alone in my basement, it currently is around 500 ppm. Lately at a symposium, it went up to more than 2000 ppm. Many monitors are available in the market. It goes beyond today's talk to talk about their characteristics. One important thing to remember, though, is that not all monitors are equal, and many cheap and accurate ones are available. So take the time to inquire before choosing. And when ventilation is not good, it's even more important to add other layers of protection. For example, filtration is a very good layer to add when ventilation is insufficient, and probably a good idea anyway. HEPA air purifiers are available commercially. Remember to avoid or turn off ionizers, which are considered deleterious to health. And also easy, cheaper, and fun to make are DIY Corsi Rosenthal boxes at home. A lot of information is available in various ways, to build them. Some are provided in the references. And just a quick remark, it's important to mention that CO2 is not cleared by air purifiers, so less good proxy when filtration in place, but still tells on ventilation of the room. And now that we've taken care of the room air, which unfortunately we cannot always bring to an ideal level, let's talk about an added layer of protection that we can control. Although it has unfortunately too often been presented as a restrictive measure, it is in reality a protective measure. In this study conducted in 2021, we can see that wearing a mask has a protective effect. I'll not dive into all the controversies and biases around the studies about the effectiveness of masking and types of masks. Laws of physics are quite clear, even with all surrounding human factors that can impact protection. Instead of debating physics, let's work on the human and comfort components. Best protection from infected aerosols will come from respirators such as N95 or KN95, as long as they fit well on the face. When these are unavailable, surgical masks are not useless, but at least wear them as tight as possible around the face and avoid big openings on the side. Many tables like this one have circulated to illustrate the increased protection from respirators and two-way masking. Unfortunately, they often have been taken as precise durations, when in fact they show a ratio of protection considering only duration. There are many other factors that play a role, such as number of sources, everything related to air quality, activities of the source, and so on. I do not have time to go over this table in details, but the link in reference leads to the full explanation, simplified or detailed. Overall, even if now seen as an individual decision, we still have to understand that the more people are masked in a room, the more risks of transmission are mitigated. And respirators give much longer protection. Also, behavioral specialists would certainly agree that there's a peer pressure effect, hoping we can make the move to wearing masks rather than remove them. Be leaders. Overall, all those layers of protection related to air quality and masking work together toward the same goal, reducing inhalation of infected particles by the uninfected receptors. The fewer infected aerosols you breathe in, the lower your risk of reaching the infection threshold. Up to you, Lynn.
So where we're at is that we need a clean indoor air revolution. And for that, we need engineers. It's going to be a three-pronged strategy: ventilation, which is really about air exchange or dilution of indoor air; filtration, which is really thought about as air cleaning, as opposed to cleaning surface. It's the air that we need to clean. And then monitoring indoor air quality. We've built our buildings to be energy efficient, but while that's a good thing, it means that we're not allowing for enough clean air into our buildings. And during a pandemic, rebreathing stale air or exhaled air from somebody else is dangerous, as we found out. It's unbelievable that we're in 2023 and we have no idea of the indoor air quality in our buildings. We spend 80% of our time indoor. As Kim Prather, one of the aerosol scientists, said, every day we drink 2 liters of water and we filter the water. However, we drink 70,000 or we breathe 70,000 liters of air a day and we don't filter the air. Next slide. ASHRAE stands for the American Society of Heating, Refrigeration, and Air Conditioning Engineers. They have been leaders during this pandemic. Early in April 2020, following the precautionary principle, they put out a statement saying there was enough evidence for transmission of SARS-CoV through the air that we needed to improve the operations of our HVAC system in our buildings. They put together an epidemic task force, and in June of 2023, just last June, they came out with a new standard 241, on controlling infectious aerosol inside our building. Next slide. But standards are not enough. We are going to need policy. We're going to need new building codes, and finally, legislation to make this all happen. Belgium is leading the way, and we should be taking note. Next slide. So what we learn as human beings is resilience and adaptation to different circumstances. Every day, we look at the weather forecast and decide how we dress. I'm from Vancouver, and I decide whether to take an umbrella. This past summer, we've learned to use the Indoor Air Quality Index to decide whether it was safe to have activities outdoors. Next slide. What we need to do during this COVID pandemic is not ignore the risk of COVID, but rather figure out what is the risk in our province or territory and adapt our behavior and our activities to how much transmission there is currently in place. And that is what COVID-19 Resource Canada Canadian forecasts aims to do. Next slide. So in Canada, when we talk about healthcare, that's a misnomer. Really, what we do in Canada and many other countries is disease care. There's very little healthcare. The only people in charge of healthcare, real healthcare, are public health. What do I mean? Let me illustrate it with a parable. So I'm from BC, and one of the activities we like doing is hiking. So imagine 3 friends going to hike on a nice summer day, and they get to a flowing river where people are actively drowning. So 2 of the friends get busy and start pulling out people out of the water, because downstream from the river is actually a waterfall. So they're pulling people out as fast as they can, preventing them from going over the waterfall. Lo and behold, they look around and they wonder where their third friend is. She's running upstream. She's basically turns around and answers to what are you doing is I'm going upstream to figure out who is pushing or what is pushing people in the river. That friend is doing public health. The other two friends that are pulling people drowning in the river, that's disease care. That's what I was doing as an emergency physician. That's what ICU doctors do. Next slide. So with COVID, we need to go upstream. We need to get back to public health. By definition, public health is about the 3 Ps. It's about promotion of health and well-being at the whole population level. It's about preventing disease before it happens. And it's about protecting health. And public health starts with the most vulnerable in our society. It doesn't leave them behind. It starts with them because if they're protected, then everybody else is protected. And that's what we need to do right now with COVID if we're going to prevent chronic disease, long-term disability, and more people suffering. Next slide.
So bottom line, it all comes to understanding the spread and available tools to mitigate transmission. Every infected aerosol not breathed counts. So consider the whole iceberg. Everyone here is aware of the whole iceberg, which is absent of public messaging. And our defense mechanism probably also contribute on keeping it underwater for peace of mind. Evaluate the situation and context. Current pandemic situation forecast. Outside, inside, few people you know take precautions, or many you don't know. Air quality when inside. Make an informed decision. Use appropriate tools. Those will vary depending on each situation and context. And everyone may sometimes choose to take a greater risk in a specific situation, but should also act accordingly to protect others in the following days. Protect yourself, protect others, protect people with long COVID. Protection is better achieved as a shared responsibility. The more people that are protecting, the more the risks are mitigated. Lead by example. Often not easy, but if more people normalize protection, especially in public events, we can start going upstream. And keep at it. A Canada without post-COVID condition is the long COVID's web vision. Find a cure, yes, but less infection means less long COVID. Transmission can be mitigated, and members of long COVID can lead by example. Thank you.
Thanks very much, both to Dr. Filiatrault and to Anne Bhéreur. I really appreciate such a clear and concise overview of prevention protection for infection and reinfection. We're going to turn now to our second speaker. I'm terribly sorry for the lack of time for questions, but we had technical difficulties at the start, and thanks for your patience. Over to you, Dr. Vaisman.
Hi, thanks for having me. I'm Alon Vaisman. I'm an infectious disease and infection control physician at University Health Network. So I have no disclosures to report, and the objectives of my talk today will be to discuss the currently circulating variants, where we are, how we've arrived here, and then also the current available evidence on the impact of vaccination and antivirals on post-COVID syndromes. So the story of the variants began in late 2020. So the pandemic began in early 2020. We had viral strain, the wild type blue strain that was first detected in the UK, that was called the alpha variant. And then after that, the beta variant subsequently later, and then in November, late in that year, we found there was a gamma strain. And then in early 2021, here in Canada, we experienced a delta strain. What we found with these new strains of COVID is that they were progressively more transmissible and more virulent. They're resulting in more case fatality, more morbidity associated with it. And then that all changed when Omicron arrived, and that was in late 2021. In Canada, that started to develop, especially in December of that year. In January, it really exploded. So you can see here a visual depiction of the proportion of cases caused by each of these variants. So in the beginning, it was all the wild type strain. And then by the end of 2021, we're seeing the development of alpha, beta, gamma, delta. And then after that point, by the end of the year of 2021. Basically, all of it has been Omicron since then. So for nearly 2 years now, we're almost at the 2-year anniversary of Omicron. It has been entirely Omicron and its subvariants. And that's really where we've been for the last, more than half of the pandemic now, actually. So when you look at the development of the evolution of the virus, you can see that the development of alpha and beta and gamma, they are over various lineages, and delta actually was branched off in a different location. And delta actually, before Omicron, delta was a very deadly, very transmissible form of COVID. But Omicron, this subvariant here, started to develop in the end of 2021. And since then, we've seen progressive changes within Omicron. So everything we've seen them is just a mutation within Omicron. So this subvariant of a subvariant has been progressively developing. And coupled with this, with Omicron, we saw a very highly transmissible virus with unprecedented case numbers. I mean, it basically dwarfed all the other waves that preceded it in 2020 and 2021. And coupled with mortality that was dropping. So per case, the mortality was dropping. So the trend was completely shifted from a more virulent virus to a less virulent virus that was more transmissible. So when you look at the overall mortality rate, the first 2 years, you could see it was quite high. Part of the reason that the mortality rate fell, even though Delta arrived, was because of better therapeutics, because of vaccination, because of immunity. And then in 2021, and especially the beginning of 2022, you could see there's a significant drop in mortality. And that has continued to drop since that time. And there's many factors associated with that, but one of the main ones is that Omicron and its subvariants are intrinsically less virulent than its predecessors. And in terms of the case numbers I was alluding to earlier, you can see that right in the beginning of 2022, here in January, across Canada, the numbers were sharp, vast increases. What actually changed, the reason we don't see sustained numbers going up and up more, was because the testing criteria for the general public changed, and also the availability of rapid antigen tests. So we're not actually documenting a lot of the COVID infections. There's far more COVID infections than we even know about. But this basically shows you that this wave, using the testing criteria we had up until that point, far exceeded anything we had before that. And you could see the first wave here, how small it was compared to this. And how bad was Omicron in terms of its transmissibility? So essentially, nearly all Canadians have had COVID at this stage. Hard to estimate exactly how many, but it's upward, more than 99% of Canadians. This is true for most countries in the world now. Almost every single person in the world has had COVID. Just to give you a rough kind of comparison, the WHO estimates that yearly there is 1 billion flu cases. The reproductive number of flu on an average flu season is between 1 and 2. The reproductive number for COVID when it arrived, it was very high initially, 10, but it stabilized around 2 to 3. So the reproductive number of COVID being twice or thrice as bad as flu, which causes 1 billion infections a year. Just think about how many more COVID infections that resulted in. So why did Omicron change everything? It also, because it was more immune evasive. That is why it was more transmissible. And as a result, there was more reinfections. Before Omicron, reinfections were uncommon in that first 18-month period or so of COVID in Canada. But since Omicron, reinfections have become the norm. People have become infected multiple times. And then what we saw a pattern emerging with COVID is that every 3 months or so, we were getting subvariants emerging. And then we were seeing subvariants of subvariants emerging. So if you look at the current evolutionary tree, you could see first we had BA1, then BA2, BA3, BA4, 5. Within each group, we're seeing new subvariants forming, and then some variants merging into one group. XBB is a good example of that, where it's 2 subvariants of the BA2 merging together. So we're not seeing any more of Alpha, Delta. That's completely gone now. We're only seeing Omicron. And in fact, the earlier Omicron strains are also gone now. So if you look back to this chart, this is only in the age of Omicron. You can see that essentially every 3 months, we're getting new variants, and basically they replace the old variant. So whatever you knew about 3 months ago is now changed. So we're seeing subvariants mostly now it's a subvariant within BA2. And you could see now there's a new variant that's rising now, the XBB1. That's what we're seeing out in this form here. And there's a recombinant version as well, as I mentioned. And this is just looking at the last 12 months, the same chart, so you can kind of see the expansion. Over just the 12 months, you could see how fast this process occurs. it basically occurs every 2 to 3 months. We're seeing a new variant become more dominant. And within this kind of group, you're seeing also, again, subvariants. So again, just to show you back to where we were in the original chart, remember we had the wild type virus, we had development of alpha, beta, and then delta. And now we're only within Omicron. And now we're essentially only looking at subvariants within this group, within the BA2 group. That's essentially what we have now for the last 6-12 months or so, is more and more subvariants within this. So it's kind of like a narrowing in of variants within that group. This is what we have right now in Canada. So the last data that we have available from PHAC was from late October. Is this strain called EG5, and EG5 is one of these BA2 subvariants. And you could see very clearly here, this nice light color, how it's expanding within Canada over the last few weeks. This is just looking at the late summer till now. Even just within this short period, you could see how the proportions of variants changes. It's constantly shifting. And so what is this EG5? It's a descendant of XBB.192, and that's, again, within BA2. What is BA2? It's a subvariant of Omicron. And we think that it's presumably vaccine responsive. So I'll get into that in just a second, into why we think that and what the data has shown us. So in conclusion, when we talk about variants, Omicron variants are inevitable. We are seeing basically all the time, there's continuous viral change, viral mutations occurring. And as a result of Omicron, which changed the landscape, we're seeing a progressive decline in mortality for many reasons: vaccination, passive immunity, but also, I should say active immunity from being infected, but also because the variants themselves have become intrinsically less virulent. So leads us to the question of vaccines. So these viruses are rapidly mutating. So what has this unfortunately resulted in is that the vaccines have become less effective. When we think back to exactly 3 years ago, December 2020, when vaccines first showed up, the very first Pfizer and Moderna trials showed that essentially prevention against infection was 100%, that prevention of hospitalization and death was 100%. That was the very first randomized controlled trial looking at vaccines in late 2020. That's what we knew about vaccines. This kind of philosophy is what actually led to mandates for vaccine mandates, for example, that thinking. But again, as the new variants showed up, especially with Omicron, this changed. And now those vaccines that were previously 100% effective are far from that. And it's resulted in new vaccines needing to be made. Just to give you a sense, there is a whole gigantic soup of different mutations that define what these variants of Omicron are. And you could see what they do and the various types of things that they interact with that they result in immune evasion. So, for example, they resist the neutralizing antibodies that the body makes. They make it easier to fuse inside our cells, or they are tighter fusion to the receptors on our cells to get inside. So all of these variants have all these mutations that are piling up, sometimes mixing with one another, that creates a strain that's harder and harder to vaccinate against and harder for our immune systems to evade. So currently in Canada, we don't have the Johnson & Johnson anymore. We just have these 4 vaccines available. Everyone is very familiar with the Moderna and the Pfizer vaccines. Those are both mRNA technology. mRNA technology is a novel form of vaccination that was created during the pandemic. Then we have the AstraZeneca protein vector and the Novavax, which is not as commonly available, not as commonly used, but is recently been approved in 2023. This is a protein-based. A viral vector vaccine is one where adenovirus, another human virus, is given to the patient in an attenuated fashion that delivers the protein that your body responds to. But the problem is that the data has been piling up for 2 years now that these vaccines are far less effective against the new variants. You could see here that over a course of a short period of time, over a course of 100, 150, 200 days, that the vaccine effectiveness very rapidly drops, whether it's 2 doses, 3 doses, or at the bottom here, 4 doses. This BNT here is the Pfizer, and this CoronaVac is a Chinese vaccine that has been used widely over there, but similar concept. No matter which vaccine we're talking about, we could be talking about AstraZeneca, talking about Pfizer, Moderna. The same thing has been shown multiple times now. This is an example. This is actually data that was taken from Canada, presented by or published by Canadian researchers in Ontario, looking at pediatric cases. You could see after your first dose, your vaccine efficacy drops. After 2 doses, it drops. And it's not even starting off at a high, starting off at even 24, 66%. On the left side, you're looking here at infection. On the right side here, you're looking at hospitalization. So the protection against infection, which we talked about being 100%, nowhere near that anymore. It's very, very ineffective comparative to what we had before. On top of that, it very quickly fades. Within 120 days, you're at a point that many patients will be back to baseline in terms of their risk of picking up infection. The mortality benefit and hospitalization benefit likely lasts a much longer time. But in terms of simply picking up infection, unfortunately, the vaccines are not as good at doing that anymore, not anywhere close. This is another example of how quickly it takes that, just alluded to earlier, the waning of immunity. This was published in JAMA in May. This was during the Omicron era. Basically, they looked at a variety of various vaccine types, so the Pfizer and the Moderna, whether you got boosted, 2, 4. What basically you're looking at is, as you go down the chart, the efficacy, the vaccine effectiveness declines when you look at further out from their initial dose. So back, if you're finishing your third dose, your second dose, whatever the case may be, it steadily declines to the point that when you're looking at it, 9 months later, you're at less than 10, 15% vaccine effectiveness, very close to the baseline, actually. So that is the unfortunate reality we're faced with Omicron, is that the vaccines are not providing as good protection as they used to. So in summary, regarding vaccine efficacy, there's waning impact of infection. The impact it had on decreasing illness and hospitalization is also decreased. But what about its effect on post-COVID syndromes? So this article, which was published in October, is a systematic review of the literature looking at studies that examine the impact of vaccines on post-COVID syndromes. This occurred over the course of the pandemic. Only 8 of the studies included here actually cover the Omicron era. Most of them were pre-Omicron, which is important to recognize when you think about how Omicron has changed the landscape of immunity and your ability to protect against the virus. Unfortunately, of course, what plagues most post-COVID syndrome studies is that the definitions were not standardized between the studies, and a variety of observational study designs were used: prospective, retrospective, case controls, very large cohort studies, even including 300,000 patients, all the way down to small, several hundred patient studies. What they found was that the overall pooled odds ratio, when you look at all the studies that they included in the meta-analysis, came down to a 68 points or 0.68 odds ratio. In other words, your odds of developing post-COVID syndrome compared to somebody who wasn't vaccinated was 0.68. Still a bit hard to understand odds ratio, but it may be easier to understand vaccine efficacy. Similarly, like we talked about preventing infection or hospitalization, you could see here on the far right what that vaccine effectiveness is, I should say. So for example, for fully vaccinated people, if you get vaccinated, if you pool the before and after, it's 32%. If you only look at the before, it's 37%. So not that great in terms of preventing post-COVID syndromes. It's not that bad, but probably all lower than what we anticipated. For those who got fully vaccinated after they had infection, unfortunately, there was no impact. This was driven by a single study that was very large, so it's hard to know, but based on this analysis, there isn't any impact in preventing post-COVID syndrome in those who are vaccinated after infection. So that's basically the findings of the studies, that the overall estimated vaccine effectiveness against post-COVID syndromes was 38%. With 2 doses, it was 32, and with 3 doses, it was 69. But keeping in mind that this is, based on what we know from this, it's only beneficial if you get vaccinated before you're infected. Now that we know that more than 99% of people on Earth have been infected, right? So this kind of limits the understanding of this data, kind of limits the application of this data. What about antivirals? So vaccines aren't doing a great job protecting us against post-COVID syndrome, or let's say they're doing not as good a job as they used to. What about antivirals? So we have no RCTs looking at this, but we do have observational studies looking at both molnupiravir and Paxlovid, the 2 most commonly used antivirals used for patients with early COVID infection. So if you're infected with COVID and you take, in this case, Paxlovid, your relative risk of getting a post-COVID syndrome is dropped down by around 26%. And that absolute risk reduction is around 4.5%. And also, we know this from other studies, but also reduces your risk of death and hospitalization. Similarly, for molnupiravir, made by another drug company, the relative risk is also reduced, not as much in the Paxlovid study, but around you could see here it's around 17% relative risk reduction. So in conclusion, for to summarize what I've spoken about, Omicron is highly transmissible. Infection is highly probable. Nearly everyone in Canada has had COVID, and probably more than half of them have actually had it more than once. The new variants are inevitable. And the advice I'd kind of give to people, or to when I talk to media about this, is that there isn't really much point in focusing on this variant or that variant, because as long as it's Omicron, we kind of know how Omicron functions. The mortality is comparatively low, the transmissibility is comparatively high, and the immune escape is continuously getting worse and worse. As you know, I didn't actually mention this, but there was the XBB.1.5, the monovalent vaccine that was created in October from both Pfizer and Moderna, try to address this issue. The problem is that we're constantly chasing our tail, right? Because you could see the variants are constantly being formed. So we can create a new monovalent vaccine today. By the time it gets to market in 3 months, a new variant will show up. So unfortunately, it's not a fight that you can win from that perspective. This is somewhat analogous to what we do with flu vaccination, although with flu, the variants, or I should say the mutations are a little bit more stable, or much more stable than in COVID. Vaccines are only partially effective against preventing infection or death. And also vaccines are only somewhat effective, and virals are fairly effective, I'd say, at preventing post-COVID syndromes. So sorry, it's going a little bit fast, but that's the...
Thank you very much, Dr. Vaisman. That was super helpful. I did mention in the chat that we'll stay a few more minutes just to address some of the questions. The first one that was posted from Adriana, we have wastewater data on many places that show the amount of infections higher than the start of the pandemic. Is this correct?
Yeah, I mean, because the sheer transmissibility of Omicron, that's just going to continue. The amount of COVID cases, until we get a stable amount of immunity in the population, is just going to continue. Also, we have fewer measures in place to prevent COVID transmission. But when you compare the wild type strain in 2020 to what we have now, it's incomparable. Like this virus is far more transmissible than that.
Okay, thank you. Also forgot to mention that there was some kudos for the prevention presentation. So thank you very much to Drs. Filiatrault and Bhéreur. Another question, if a new variant becomes more dominant every 3 months, what does that mean for vaccines? Do you feel that that question was addressed to anyone on the panel?
Yeah, as I mentioned, because we're constantly chasing our tail, we're always going to be behind. And just the nature of the vaccine against Omicron in general is going to be partially effective. But basically, that's been the approach with flu, is to try to create a more updated vaccine as much as possible, to the degree we can predict what the next variant is.
Susan, I just want to weigh in on that a little bit. I think it's fair to say that we are chasing our tail because of the way we're dealing with the spread of transmission in the community. So by letting it rip, we're actually allowing the virus to spread and acquire more mutation and select out for vaccine evasiveness. But it's not a immutable or irreversible thing. If we have more visibility on how much transmission there is and we limit the spread and the health impacts of COVID, then our vaccine have a better chance to be protective. But it's because we're behaving as if we're in a pre-pandemic state that we are now having vaccines that are not effective as they were at the beginning.
Thank you for that. Another question about mortality rates and how they're calculated and what they mean. Basically, if 2%, or as an example, of the population died, the mortality rate can never be as high. Would anybody like to take that one? Dr. Vaisman?
Yeah, because of the sheer number of cases, the number of deaths at some points during the pandemic, especially in 2022, will look higher, even if the case fatality rate has dropped dramatically. The important thing to recognize now is that we're seeing a lot of people present to hospital when we, I've reviewed many of these cases where they come in incidentally with COVID and not due to COVID. So for example, people coming in with fractures or other things, because there's so much COVID transmission in the community, because people don't have access to rapid tests and don't know that they have COVID, people are just incidentally testing positive on PCR tests. And that's part of the challenge of understanding how COVID contributes to disease. and there isn't a lot of research, or there isn't a lot of work done on trying to distinguish coming into hospital with rather than of COVID. Although most studies show that there's a vast overestimation of that. The highest quality studies show there's quite a large overestimation.
I'd like to weigh in on that as well. So what's happening with public health is we look particularly at the 30-day acute COVID impact, but we don't look beyond 30-day. So yes, you may have an incidental COVID infection. Unfortunately, as we know with people who develop long COVID or post-COVID condition, the effect of the virus does not stop at 30 days. So even though we say severe outcomes or hospitalization because of COVID, ICU admission and mortality within 30 days, the effect of the virus does not stop at 30 days. And people that develop diabetes, heart attacks, or long COVID are in fact, So Anna's bringing up the slide to show that we need, in 2023, we need to redefine severe outcomes, because if your child develops diabetes because of COVID or develops immune dysfunction and keeps getting infected, that to a parent is severe outcome. And so is also premature heart disease and diabetes. So we have to be a little bit concerned about saying, oh, it's just it's with or it's from COVID admission. Every infection counts. Thanks, Anne.
Thank you very much. We have a number of questions that we're just not going to have time to go through, but we can have a think afterwards about whether or not we can address some of these on the online recording and slides that will be there. Angela, I'm wondering if you're able to access your mic, if you'd like to say anything in response to any of the questions.
No, I just want to thank the speakers for a very informative session here, and apologize again for the technical difficulties. I think we all learned a lot. Yes, if we don't have COVID, we can't have long COVID. So I think it's important to try to avoid. And thanks, Dr. Vaisman, as well, for sort of discussing the variants, because the HV1 variant was in the news, and it looks like it's one of these subvariants of the BA2. Is that correct? Or XXB, whatever, as well?
Yeah. Yes, all the recent ones have been under BA2.
Yeah. So, and currently, because there are, vaccines available for the XBB1, I would just ask you, would you recommend people taking the vaccine?
Sure. If you fall within the NACI recommendations of getting the vaccine, getting the updated one makes sense. Ultimately, I don't think it makes too big of a difference. We actually don't have high quality data. The NACI statement actually only refers to in vitro data now. We actually don't have high quality data to show us how often we should be boosted anymore. But if we follow the NACI recommendations, then yes, we would get that dose.
Okay. Thank you so much.
Very helpful.
And Dr. Bhéreur.
Yeah.
Oh, yes.
I'll just add one little thing, because I just saw a question, and I'm sorry I pushed a lot on my voice, so now it's not that stable, but asking what should workplaces should know. As we said, protecting is not 100%, but knowing is key. So understanding how it spreads, how you can protect, and then make informed choices is what we have to go back and start. We have to reverse sort of the messaging that it's not there anymore, and take into account it's there, and do what we can, even if not 100%. So that would be what I would say for workplaces. If people understand, at least there's some things we can do.
Great. Thank you very much. Thank you very much to all our speakers. Extremely useful and helpful, and a number of excellent comments in the chat about how useful it has been. So thank you very much. Take care, and it will be posted on longcovidweb.ca, ideally within the next few days. I'll just ask the speakers to confirm that they can post their slides in addition to the recording, and then we can do that alongside. That'd be great. Thank you very much. Take care, everyone.
Thank you.
Be safe, be vaccinated. Bye-bye.
Bye-bye.